Hello, everyone, and thank you so much for joining us today. My name is Nicole Lamberson, and I am a physician assistant, and I am also a member of the Medicating Normal team, where I volunteer doing outreach for the film, and I also facilitate important conversations like this one. Today, I'm excited to bring you this interview with one of the wonderful individuals we have met along the journey of making and screening our film, Medicating Normal. Our guest today is Dr. Clive Sherlock. After 3 years working as a hospital doctor, he studied philosophy and then returned to the NHS to specialize in psychiatry and clinical psychology. Training in psychoanalysis, Freudian and then Jungian, cognitive behavioral therapy, which is also known as CBT, neuroscience of the brain, and drugs left him unconvinced because he believes it is all theoretical, not insightful, and it does not lead to safe and effective understanding or therapy for psychiatric conditions. It was clear to him that everyone coming for help or therapy wanted to change how they felt and how their moods and feelings affected them. Ever since, he has been teaching people how to cope with the emotion that underlies their suffering. This has been possible both face-to-face locally and online globally. The way he works is unusual because it is based on an understanding of emotion that is radically different from both conventional and alternative ways found in Western society for dealing with emotional, psychological, and mental distress. This understanding is based on insights derived from years of study and training in Far Eastern philosophy and psychology, specifically in Zen Buddhist practice, with its emphasis on practical measures for coping with emotion. He was first introduced to Far Eastern philosophy and psychology while studying philosophy, following which he started a lifelong study and training in traditional Zen Buddhism. In recent years, he sees more and more people tapering psychiatric drugs, often with heart-rending suffering, to help them discontinue. You can find Dr. Sherlock at adaptationpractice.org, and that link is also listed in the description of this video. So thank you so much for joining us today, Dr. Sherlock, and I'm really excited to talk to you. And so I guess I'll hand it over to you first to see if there's anything else you would like to say about yourself as sort of a general introduction to our audience today.
Thank you, Nicole. And please call me Clive. Everyone else does.
Okay.
And I would say what I'd like to add is just that there is one main purpose of adaptation practice, and that is to find a way out of suffering, particularly the emotional, psychological, and mental suffering, all the mental anguish, all the depression, the anxiety, the stress that so many of us, if not all of us, go through at some time in our life. So that would be the main other point that I would just like to emphasize, and then we will talk more about it, I hope, as we go on.
Yes. Okay, so you and I have spoken previously, just getting to know each other a little in preparation for this interview. And you first reached out to us at Medicating Normal because you saw the film yourself and you wanted to have what you call your trainees, which we'll get into later, watch it as well. But you told me after watching Medicating Normal that you resigned from being a psychiatrist for the very reasons that we made the film, and that you haven't prescribed medications in over 35 years. Can you tell us more about why you made those decisions and, you know, how it was received, what it was like? Because I imagine, you know, training to be a psychiatrist it takes a lot of time, investment, money. And so I'm sure it wasn't just a decision you made lightly just to walk away.
No, that's absolutely true. And just to get the sort of timing clear, I resigned from the NHS, which is the National Health Service here in the UK, as a working in the hospital. That was about 35 years ago. And then, yes, indeed, we talked about it after having seen the screening of Medicating Normal, which I want to say yet again is such a wonderful film. I mean, it's so well made, and it has such a strong message in it. But the difficulty is this, that I, like all my colleagues, had been told by the management, by the managers, that I would have to prescribe medication for people, for example, who are depressed or anxious or stressed. I can say something about people who have what you know is also called psychosis later, but this is particularly the people who are depressed, anxious, stressed, and then all the different variations that come up from those emotional problems. And I was not prepared to do what they said. I knew already that there was a safer and more effective way of dealing with them, and not having the harm of side effects and then withdrawing all the withdrawal effects. And tapering was probably not known of at all. I certainly hadn't heard of it at that time, some 35 odd years ago. And it was a very difficult decision to make. I mean, I had a promising career in a government financed, well, actually not government, it's state financed, comes out of the taxes and the national insurance, the whole running of the NHS. So I had a secured job there, a post, a career, with a very good pension promised at the end of it. And I mean, why did I give that all up? Well, I would say, just in a few words, that I am no Dr. Faust, and I did not intend to sell my soul to Mephistopheles, which I felt I would be doing if I continued to do what I was being told now to do against my better judgment by an institution which I thought was medically and morally wrong.
And you said too, some of your colleagues left with you, is that correct?
I'm aware of, just in Oxford here, that 3 other colleagues left. One of them was principally a psychoanalyst, so he was a psychiatrist, but he worked mostly with psychoanalysis rather than medication. And the other one had gone into homeopathy. I mean, whether I agree with those or not is another matter. It's actually irrelevant. But they also resigned at the time because they were not willing to do what they were being told to do. And before that, I think I'm right in saying, I mean, I haven't studied the law about it, but I think that doctors have always, as far as I'm aware, have always been able to give whatever form of treatment or therapy or help they deemed in their own knowledge and experience to be best for the patient. And now we were being told by managers who had no medical training at all that we had to change how we behaved towards our patients.
And even that long ago, you were aware of, I mean, because a lot of these medications have only been around for, a very limited period of time, which is sort of what makes them, I don't want to say dangerous, but we haven't had them for long periods of time. So even 35 years ago, you were aware of the risks and harms and dangers of the medications themselves.
Well, that's true. And 35 years ago is only mid 1980s, isn't it? 1986, something like that. And certainly we had drugs like amitriptyline and the no, what was the other one? I forget. No, tryptamine. I mean, these were called tricyclics, and I mean, they also were cardiotoxic. So some people in the States and in the UK, I was reading, were dying from heart disease by being given these drugs inappropriately. So yeah, I was aware of harm that could be done, but the main issue for me was that I was not seeing people get better and recover. I'd worked in hospital medicine, and in hospital medicine, you know where you are. You know how to diagnose people, and that diagnosis is based on evidence. It's based on observation that you can actually see objectively. It's based on a number of tests, like say for the heart, it can be X-ray. Nowadays we have scans as well. Amazing that you can see heart valves, sort of going like this. You can see the valves actually working on a scan, and you can do an ECG, and you can listen to the heart. You can't do any of that in psychiatry. It doesn't exist, and all the blood tests that you had for the heart as well. And then at least we knew. So if we knew that there was no cure for, say, heart failure, we knew the limits, and it was very hard. But sometimes we would have to say to people, look, I'm very sorry, but there is no cure for this. We will do all we can to support you, but there's no cure for it. And then in psychiatry, yeah, well, there's first of all fundamental problem, and that is the diagnostic system isn't the same. It's nothing like that in medicine. So I wasn't seeing people get better. I didn't know what I was doing in trying to diagnose depression, anxiety, stress, psychosis, paranoid delusional psychosis or something like that. There's nothing equivalent to that in medicine that we have in medicine.
So that kind of leads us into the next question. Your bio states that your training in psychoanalysis and CBT, or cognitive behavioral therapy, and neuroscience of the brain and drugs left you unconvinced. You say because it's all theoretical, not insightful, and does not lead to safe and effective understanding or therapy for psychiatric conditions. So can you elaborate on that a little more?
Certainly. When I've just been comparing psychiatry with medicine as a whole, general medicine. Say now we would say medicine and surgery. All the other fields of medicine, bar psychiatry. But in a different way now, as you've mentioned, I have trained actually for 25 years in a Far Eastern practical philosophy stroke psychology, which was, we can perhaps talk about later if it's appropriate, in Zen Buddhist practice. And I have to say, as an aside for one moment, but it's an important aside, is that adaptation practice is not Zen Buddhism. It's not religious. It's not trying to persuade anyone to have any change in their beliefs or their thoughts or anything about religion or spiritual matters. But the difference then between an Eastern way, which is all based on introspection, meditation, and again, that which we can talk about later, that's not the same as what many people think of meditation here in the West. This is a way that comes from probably about 3,000 years ago, in northern India in particular, where people were learning not only to look at things objectively. So for example, here I can describe a pencil here in detail objectively. You know, I can say it's so many centimeters or inches long, and it weighs something, and it's a color, and etc. like that. But they were learning to look at what is going on inside themselves, in their consciousness. Now that leads to what we generally call insight. We're seeing what is going on inside. But the different ways that you've listed of training in psychiatry is not doing that. It's always thinking about things. So, for example, you know, what happened to you? Where were you born? You know, what happened to you as a baby, as a child? You know, can you remember how your mother was to you, your father was to you, and so on? And that is all thinking about an object. There's me thinking about my childhood, what I can remember, or what I've been told happened. But introspection is quite different. It's not doing that. It's just sitting here and waiting, which might seem remarkably passive. But if I just sit here quietly for a moment, I start to notice that there are sounds around. I can hear traffic in the distance. I can hear where I am. It's now about 6:20 in the evening, so it's getting dark outside. There are a few, say there's a blackbird outside somewhere singing its evensong. I was completely unaware of that. But if I keep quiet for a moment and stop trying to work things out intellectually, because I've learned a theory that my depression, or my anxiety in particular, those two, are due to troubles I had in early childhood, or maybe a bit later in childhood and then in adolescence. And this is not to say at all that any sort of physical or emotional or any other trauma that happened to me as a child is not affecting me now. It is, almost certainly. I mean, just the fact of my birth is affecting me. That's why I'm here at all. So it's not doing that. It's what we interpret or misinterpret and deduce from that. And if I well, I think it's summed up in the saying, once bitten, twice shy. You know, I love dogs, a dog bit me, and from then on I'm frightened of dogs, even though no dog has bitten me since. And so something has happened in the past, and then it affects how I react to people, to situations. It might affect my dreams. It might affect how I get off to sleep at night, because it keeps returning as a like a phantom, actually, in the mind. So I regard that as theoretical. It's I mean, Freud's theory, you know, we're then looking at infantile sexual development. Well, most people nowadays will find that a bit far-fetched, to say that I'm depressed because something happened when I was 1 or 2 or 3, even 3 years old, in my sexual development. That's I mean, even Jung, his contemporary, questioned that. So then, yeah, if that covers sort of the psychoanalysis side of things, roughly, to say that they are based on theory, whereas if I stub my toe, it hurts and I yell out in pain. And there's no theory involved in that. I'm in pain and I'm hopping around in pain because it hurts. And I don't need to theorize anything about that at all. If I tread on the dog's paw, it goes like that. It
Yeah.
yelps, and there's no theory in that. It is just a direct experience, and that's what adaptation practice is then we see is all about.
Okay. So I guess we can move on a little bit into adaptation practice, which is the way that you work.
Yes.
You say that it's unusual because it's based on an understanding of emotion that's radically different from conventional and even alternative ways found in Western society for dealing with emotional, psychological, and mental distress.
Yes.
So try to tell us more about your specific understanding of emotion and how it's so radically different.
Mm. I have to start off saying that we in the West, we're at a disadvantage because it seems to me that very few people know what emotion is. In a sense, we all know what emotion is. Particularly, we know what the word emotional is. You're Clive, you're behaving emotionally. And what does that mean? When I was not so long ago, I lost count of how many times I had been told to, Clive, for goodness sake, contain yourself, because I was over the top in some way. What does that mean, contain yourself? It actually means contain the emotion, because it's this energy bubbling up inside and making me too agitated or too excited or too upset.
Mm-hmm.
And to have some insight into that, when I turned to psychiatry to start specializing in psychiatry and psychology, something occurred to me, and that was that everyone coming to see us in the clinic or the hospital came for a reason. And that was because of how they felt. I thought, yes, but our feelings are due to emotion. What is emotion? And I asked the professor. I was in London, first of all, at Charing Cross Hospital, big teaching hospital in London with a big department for psychiatry. I asked the professor, and I was told, well, don't worry about that. It was regarded as an epiphenomenon.
Mm-hmm.
And okay, it's just about how people feel or something like that. But but surely how they feel is why they come here, is why we're trying to help them. And then when I moved to Oxford a few years later, it was the same answer. It was unimportant. Not enough is known about it. So I turned to the literature to see what I could find about emotion, and there was really nothing. Some years later, a Dutch psychologist, clinical psychologist, Nico Freudian, in Amsterdam, he who wrote a book called The Emotions, and I went to see him later, just a few years ago. And he had a fairly good idea of what, I mean, that sounds awfully arrogant. He had a fairly good idea of what I also think emotion is.
Mm-hmm.
And he talked about it as action readiness. That the emotion is like, you can imagine a cat that is here like this, looking at a mouse just there, and is about to pounce. And this the emotion is that state of being like a wound up spring, ready to go, sort of like this.
Mm-hmm.
But what I had come to was to go back to biology. Biology is the study of life. I thought, if we don't know what emotion is, perhaps we will find a clue in biology. And indeed we do. Because if you and everyone else listening remembers from school biology that there are whatever number we go for, 5, 6, 7 characteristics of life. That means all forms of life have certain characteristics, both plant and animal. And they are movement, nutrition, respiration, excretion, reproduction, sensitivity, and so on. In other words, they are what make us alive. And the fundamental one to them all is movement, because they all involve movement. You know, breathing and then respiration involve movement. Nutrition, eating is movement. Everything of it, about it, is movement. And I thought, yes, indeed, especially for animals, like us as well, that the primary fundamental function of life is to move. And I thought that, you know, that movement is not random or chaotic as it might often seem. It's always moving. It's going towards what is needed for survival. And then we start to go more into the insight element you mentioned earlier. That survival is of the body itself. It's the cells and all the organs of the body, because they all the cells need energy, which we bring in as food and nutrition. It needs glucose, also there as well. And living as we do in a dangerous, often hostile world, with volcanoes and earthquakes and tsunamis, but especially with other human beings, we are able to get away from the threats and dangers to this life itself. I'm talking about life of the body, not yet talking about the things I want and how I feel. It's just the life of the body. It's fundamental. You know, if you're trapped, as I have been long time ago, underwater, I mean, you just become desperate for air. And this enormous force comes up inside you to get up and get air. So I was starting to get an idea of what emotion might be. It's this movement in the body. And we feel that as an urge. You know, we have an urge. You've got hunger is an urge to eat. Thirst is an urge to drink. We feel it in that way. And then, just out of interest, if we look up the word emotion in the English language, it comes from the French émouvoir, which means to stir, to excite, to agitate. That's interesting. And that it all comes from Latin, as most of these words do, and it means to move. So this is a much better clue to what emotion is. There's something of an energy state in us which is affecting us. It's affecting almost everything we do. And if I consider then, through, let's call it introspection, I look at myself, which is what we can all do, not trying to look it up in a book, not looking on the internet, because we won't find it in either of those. But if I look at myself, I notice that if I can have what I want and I can avoid what I don't want, then life is fine. I'm contented, I'm happy, everything is good. But if I can't have what I want, or if I can't get rid of and avoid what I don't want, noisy neighbors, or a memory, or a feeling, a mood or feeling, anything like that, you know, or stomach ache, anything like that, if I can't get rid of it, to varying degrees, emotion will come up inside. You know, when I stub my toe, it's ah, and then immediately is emotion with that. Fear, anger. And that emotion drives me in what I say and what I do and what I think. And I can demonstrate that. Just a pencil. I go to pick it up and it slips. I go, oh, blow. And if everyone can see what just happened, I'll just do it again. Of course, I'm now acting it, but I go, oh, blow. And I just for a moment closed my eyes and I pulled a face. And what you didn't see was I sort of made a momentary fist. I tensed up the body like this. So something happens. It's a surprise, it's an accident, it's a little shock, it's a little threat or something like that. And immediately emotion comes. Immediately. And it drives me what I say. I said, oh, blow. I mean, I don't think you'd have to ask too many people to find someone who used stronger language than that. Which is an interesting point, isn't it? Because what I'm really saying is not blow. I'm not talking about blowing like the wind or something. I'm actually saying, in some sense, I'm saying, oh no, to what has just happened. Like if I, which I did years ago, I drove my car into a tree, well, not into a tree, but it hit the side of the thing. I wasn't looking where I was going properly. And then, it's a sort of, damn, and getting stronger. So I say something. It's an expression of the emotion. I mean, when I go, oh, blow, it's nothing to do with the pencil. The pencil's not affecting me. It's the emotion that comes up. And I pull a face, like this. And if it's stronger than just dropping the pencil, which didn't break, by the way, I might, but I bang on the desk or table or something. I slam the door, I stamp, I might become quite aggressive. I mean, not necessarily to another person, but I'm sort of spitting and scratching and clawing and banging around because this emotion comes up and really takes me over. It drives me blindly in what I say and do. And then it goes into the thoughts. Because then I think, why do I keep dropping things? What's wrong with me? Have I got something? Is it in my head something wrong, or is it in my finger something wrong? And I'm now thinking about it. Why does this all happen to me? And so I'm starting to realize how fundamentally important emotion is. Well, this wasn't altogether a stranger to me when I started in psychiatry, because, as you've mentioned, I had already started training and studying in a Zen Buddhist practice, which is Eastern, Far Eastern psychology, you can call it. I mean, the word didn't exist when it started over 2,000 years ago from India. And I met it in a strange way. I must just go back for a moment and say, because I studied philosophy, I went off to Heidelberg University, which is a famous center of European philosophy. And it was there, not on the curriculum, but it was just by chance that I happened to be given a book on Buddhism generally, which I looked at. I thought, this is what I came to Heidelberg for. But the book was from England. It was from the UK. So it was almost funny that happened. But sometimes, you have to go somewhere else to meet something and to be open to it. So this is how I started to realize what emotion was, because this was saying that you have to, first of all, work with emotion, and to work with the emotion, you have to find it. And that's no easy matter, to find the emotion. And if I may, I'll give you an analogy for that. May I ask you, Nicole, are you a horse rider? Do you ride horses?
I did when I was younger, and I actually quit because maybe it was emotion. I don't know. The horse kept turning around and biting me in the foot, and I was young and I didn't like that at all. So, but that was my horse riding experience. Yes.
Oh gosh, I think I would have been petrified if the horse I was on started trying to bite my foot. I hope you had boots on or something anyway.
Yes.
Um, I also used to ride. I don't now, but I've now decided I would like to ride a rather unusual horse. In that, let's say I want to ride a very strong, fast horse. Let's say a Mustang.
Okay.
I want to be able to ride safely and enjoyably, repeatedly, a Mustang stallion. I mean, Mustang is very fast and strong. That's why Ford called their car after it. And I want to find one that no one has ridden before. And in fact, no human being has even touched before, and probably never seen it before. So what would I need to do to be able to ride a horse like that? And we you know, one can ask anyone that. And various options. I don't know if you want to suggest something about it.
Maybe something in the wild, that, you know, some wild horse that's, I don't know.
That is exactly it. And in fact, what I'm about to say, a woman from Wales here planned to do this and filmed it, although I can't find the film now, so I can't offer it. But she went to the States and she had to find a guide because she had no idea where to look. I mean, they're not in Manhattan, that's for sure, not walking up and down Broadway. Would she go to Wyoming or Oklahoma or Nevada? I mean, you know, no idea where to go. But the guide said, look, I'll take you to the horses. I know where they are. That's the first point. And then walking along now, looking for any clue of horses, the guide said, here are some hoof prints looking down there. And it's now me doing it. And I looked down, I say, where? I can't see any hoof prints, because I know the theory is a hoof print is like that. You know, it's the thing you hang on your door for good luck or something. It's nothing like that in reality in a print on the ground. It's just a little indentation there. And the guy says that's and I say, oh, I could see it, but I didn't recognize it. And then I see some horsehair over there on the bush, and okay. And then I see some horse droppings, and I recognize those for sure. And then I have to follow these. If they're obviously going this way and I go that way, I will never come to the horse. And eventually we go and we find the herd, and with help, we're able to catch a horse. I mean, either it's lassoed, because people, you know, the horse men and women in the States can be very skilled with their lasso. And we eventually have to bring it to where we can work with it. And that is difficult, because that horse will only want to do one thing, and that's run away, go back to the herd. So we have to have a paddock, which we've made already, with strong fence and strong gate and strong clasp on the gate, not to let it out. So we get it into the paddock, and we could keep a horse in a paddock for 10 years and it would not become tame. Like the animals in the zoo, they don't become tame. I have to be in there with it. But as she said, when you're in a paddock with a wild animal, although it's a vegetarian, you know, it's not a predator, but you can't go near it. It won't let you. And if it can't get away from you, it'll bite and kick, as you mentioned. But it'll really, I mean, it'll go for you if you get too near it, because you're a threat to it. And so then you use your knowledge, and if you can see my hand, you put some water in a bucket or trough down here, and you go and wait over here somewhere. You just keep still and quiet. And eventually, you know, the horse will have to drink, because it's one of the characteristics I mentioned of life. It will come to drink because that'll become so strong that it'll overcome any wariness or fear of you. And when it does, you start to move towards it, and it'll immediately startle and move off. But you wait, and it'll come back, and you do this again. Well, you can repeat that countless times. And eventually, you're right next to the horse, because the the horse allows you or lets you come close. And it comes to a magical moment. You're right next to this now not so wild animal. And as she said, your heart is going boom, 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 like this, out of fear and excitement both. And eventually you can come here with your hand, and it goes away, you come closer, and then you can touch it. And at that magical moment, the horse is tame. And it's not the end, it's only the beginning, because only now can you start to train with the horse. And I'm saying train with the horse, not just train the horse. The horse is, by analogy, our emotion, this strong animal nature, we can say now, in us, which is in all of us. And the question is, what has changed? The horse it looks the same, it's as fast and strong, and it can jump as high. And I look the same. I can do everything I could do before. So what has changed? And you know, we can ask ourselves, yeah, what has changed? And surely it's this process of gradually coming together, getting to know each other. It's so important in life. We know it for relationships as well. And eventually we come to trust each other. And if that trust is lost, it's finished. This is what we need to do with emotion. Sorry?
Oh, keep going. Sorry. I was going to say, so this is what we need to do with emotion. This is sort of leading into what adaptation practice is, correct?
Yes, it is. Because what the analogy of saying emotion, but there's a very important difference, and that emotion is not out in the wild in grazing somewhere. It's only ever been inside me, inside this body, the body. But I have been outside. I've gone off, particularly into my thoughts and all my distractions and everything. So I'm here, and now I find it difficult perhaps to know the way back, to come back here and to be in the body with the emotion itself, this life energy which comes up when anything excites me or upsets me. And yes, I'll stop there talking about the basics of emotion.
So I guess since you said that, you know, people, I guess when you were working as a psychiatrist, they were called patients, but now you call them trainees, the people who work with you. They come to you because they have emotion. That's what you said you've noticed. And so what exactly do you do with adaptation practice, and how is it different from CBT or talk therapy? I noticed even yesterday, I was in one of the support groups online for psychiatric drug withdrawal, and someone made a post saying, you know, I've gone to this therapist and I'm just so frustrated with it because all they want to do is talk about things that happened to me as a child or long ago. And I don't feel like that's getting me anywhere. So they were frustrated and saying, like, how do I deal with now, you know, or the future? So is that what adaptation practice is, or can you explain to us how you would work with someone?
Right. Well, I mean, that's a very good example, because it's really typical of what so often happens. And it also illustrates that something happened, or perhaps something happened in the past, which the therapist is trying to discover because of a theory. It's something from the past, but it's upsetting this other person now. And that's emotion. And that's what we need to deal with. So when I remember something that happened to me, like I was bullied at school, and sometimes in certain situations, I still, my body goes like, you know, it cringes a little bit in certain situations, because that's what happened when I was about 12. But to deal with it is not to go back and try to, well, whatever you might do, start thinking about that bigger boy who then hit me, but to look at the emotion it brings up in me now. You know, it makes me anxious, it makes me angry, and, you know, resentful, all sorts of things like that. You see, so the main difference then is that emotion is this primary force of life in us, and all manner of things, anything going wrong, whether it's a memory or feeling that the therapist I'm seeing for this is not really helping. So to deal with the emotion, and that's what we would do, but we would start it in a very unexpected way. You know, first of all, we need something like you might call it sort of training ground. Oh, and you asked me to mention why trainees. Because, and let me say that, address that first.
Okay.
And that is to say that it seems quite clear that these problems are not medical diseases. And as you know, I mean, I think you have shown this so clearly and so well in many ways in Medicating Normal. There, as you know, also there are many research psychiatrists and psychologists who point out that these diseases are not like depression. They're not like diabetes or arthritis. They are nothing remotely like those diseases in the body. So I don't call people I'm working with, or yeah, I'm working with them. I don't call them patients, because it also makes this hierarchy of sort of doctor and patient. You know, you're a sort of suffering victim in a way, and I have all this wonderful knowledge. I don't. But what I can do is I can point the way. And if you came to see me here in Oxford and you wanted to go to London, I'd say it's that way, but I can't go for you. You'd have to go yourself. But I can point the way. It's not all these other ways. It's that way. That's what we're doing. So also client, you know, that psychologists tend to, clinical psychologists and therapists usually call the people they see clients. But, you know, I feel uncomfortable with that. I thought about it, and client or customer or something, you know, it sounds too much like seeing a lawyer or you know, or a I don't know, you know, someone in a shop or something. It's too commercial. And also the other possibility was student. But student nowadays to study has too many implications of intellectual, of being all thinking. And this is not, this is practical, very practical. In that it's far more like learning to read and write. It's like learning to ride a bike. It's like learning to play a musical instrument. And you learn through this practice now how to cope with emotion. And as you learn it, you can keep practicing it. And you can practice it for the rest of your life, as many countless people do. And the more you practice, the better you get at it. But we always start off with something you can do. And for that, I would say, if I want to lift a weight, let's say a heavy bag or sack of potatoes or rice or something, and let's just say it's 50 kilograms, which is roughly 112 pounds, something like that, then I can't lift it. I need to strengthen my muscles if I want to lift it. And so what I do is I start with just say 10 kilograms, so just a few pounds, and I do this with it, and I exercise, I keep doing it, and then I find that it gets difficult because my muscles are aching, but I am getting stronger. I can now do double that, and I'm gradually getting stronger. And this is what we're doing with emotion. But the difference is we're not bearing a heavy weight up here. We're learning to bear how we feel. And if we start, I'll come back to my pencil, and if we start, I'll blow that emotion, that's possible to bear. And I think, well, I know I learned initially like that is possible to bear, but it's still difficult. You have to practice quite a lot before this will come out, because this is so fast and so strong, that tiny little emotion. But I can do it if I keep trying, if I persevere. It's nothing to do with thinking.
So in some of the reading that I did about adaptation practice and people who have worked with you, there were a couple responses. One was that people feared at first that practicing, what you're saying is that small bit at first, not letting that emotion out or learning how to cope with it, would sort of make them numb or make them like zombies if they were suppressing the emotion, or that's how they understood it. But later, after working with you, all of them said no, that is not the case, that they did not become emotionless zombies. And you told me that some of them, in fact, learned so well to deal with the emotion that they were actually angry in hindsight, that they had never been taught that they could bear emotion in the way that they learned or practiced that they could bear emotion, or angry, that the only thing offered to them was conventional psychiatry, like, you can't possibly bear these emotions, you need pills for the rest of your life, or you need to sit in a talk therapy office and go over your entire life history over and over and over again. So can you talk about that just a little bit?
Well, there's quite a bit in that, and yes, the anger that comes, it's quite a few people have expressed that, because they have found it makes complete sense, whereas the drugs, you're lost. I mean, I can't argue with someone who knows infinitely more than I do, although it turns out that they don't really know that much about the drugs. But I just have to accept what the doctor says, or what the psychologist says. I just have to accept it. And I can say, well, okay, I will do it or I won't. But usually we have been so, what shall I say, persuaded or educated in our whole social system that we believe that, first of all, as you said, that I shouldn't feel like this. But we might say, why on earth not? The extreme or very severe example is someone I love dies. When my mother died, I mean, for goodness sake, dear doctor, I mean, allow me more than 2 weeks to feel grief. I've just lost my mother. I don't want to be labeled as depressed after 2 weeks, as if the sort of clock runs out. So we're really talking about this ongoing emotional difficulty, and Why is it that doctors haven't learned this before? Well, it's not known. Only a tiny fraction of all the vast texts and understanding from, say, China, for example, and Japan, very few of them have been translated into European languages, and therefore English and USA. Very few. So we know very little. When I started, so this is now 14 or just under 50 years ago, I mean, you go into a big bookshop and there would be, you know, perhaps 6 or 7 books on Buddhism. Now there are 6 or 7 sections or departments on Buddhism, but very few of them are actually from the original texts. You know, it's usually people writing about something which they haven't themselves experienced fully. So, which I might just say that I've almost finished writing a book about this adaptation practice, which will then hopefully be published later this year or next year sometime. And that, I hope, will redress this gap in our understanding and knowledge about it. But of course doctors don't know about this. Of course they don't. I mean, why should they? They don't, they're not inclined or encouraged to study Far Eastern psychology. They all follow the main line that we have in the West. Of course they do. And it's not surprising, because it goes, and all medicine has always done, right from Hippocrates about 400 or so BC, is that the doctor or physician, you know, learns, observes and learns and passes it on to the next generation and the next one and the next one. And it's all come down these 2,500 years from ancient Greek and through various other countries, accumulating this knowledge. Well, the teacher is not going to easily give that up and say, actually, in psychiatry, I'm only talking about psychiatry now, is not easily going to give that up and say, I've been working with this all my life and I was wrong. Very few people have the integrity to do that.
Makes sense. So let's see. We've been talking for an hour. Do you have time for a couple more questions, or are you in a rush to? You do. Okay.
Oh, no, I'm not in a rush at all.
Okay. So there are lots of people on psychiatric medication that we know, and a lot of them are either harmed by the medication, or they feel like it's not working or it's not helping. So if you have trainees that come to you who are on medications and they tell you this, or they want to come off, how do you work with people like that?
Yes, well, I think that's a special problem, because they usually know, or they soon know, that I'm not working with drugs. And I make it very clear at the beginning that I do not prescribe drugs. And I do not take responsibility for drugs prescribed by other doctors. That's the prescriber's responsibility. Again, as is shown in the film, Medicating Normal. And it's so obvious once we look at it and point it out that people are frightened. You can list them. They're frightened, they're angry, they're resentful. They are almost in despair, feeling hopeless and helpless, because they're on this. There's something inside them which they can't just get rid of, and they don't want it in here. So what I say initially is, this practice, I can show you and tell you what to do. I can help you with it. I can support you. I give people my phone number. I say, you can call me anytime, but I'd prefer, if possible, that you email me. Because, like, so if someone called me now, I wouldn't answer the phone. Actually, my phone's off, but I wouldn't answer it, because it would be so inappropriate at the moment for what we're doing. And as soon as we've finished, it'll be back on. So, you know, sometimes I have to be indisposed, as we all do. But I make it very clear that we're working with emotion. We're working with how you feel now. And the practice will help you get through these very difficult emotions as you start to taper, for example. I try my best to work with the prescribing doctor, but they often don't want to know. They just ignore my letters and so on. Some of them do. And there are 2 doctors here in the UK who have actually become very interested and have changed their prescribing habits. You know, not just because of me, no, not at all, but because they have then been introduced to all the publications and so on. And I tried to get them to watch Medicating Normal as well. But I, you know, whether they do or not, I also will put, when appropriate, I put people in touch with the tapering strips group in Maastricht at the University of Psychiatry there, with Dr. Peter Groot, to pronounce it properly, or almost, so that they can get real help in the actual drug side of it. While I'm saying you can do this and this and this, which we haven't really talked about what to do in dealing with the emotion.
So I guess, is adaptation practice a little different for someone who is on medication than someone who is not on medication? Or is it would it be more ideal to do adaptation practice and never have to go on medication?
Absolutely, yes. It's much better idea to learn to swim before you go off in a little boat in the middle of the Atlantic Ocean with no life jacket. Learn to swim at home in the harbor or in the swimming pool, you know, where it's relatively safe. So that's always a better idea. But the first part of your question is that people who are either withdrawing or want to withdraw from prescribed medication, or if it's opioids, which they've got hold of themselves, or cocaine or something, or heroin, whatever it might be, which is a different, as you know very well, is a different aspect, because they are then become addicted, whereas we're talking about becoming dependent, which I'm afraid people have to look that up themselves, because we don't have time to look into the difference. But the main difference for people who are withdrawing is that it'll take longer usually. You know, it's like say trying to heal a sprained ankle which we're still walking on. You know, the damage, so to speak, is still being done because we are taking this drug. But I think the hope and seeing like the light at the end of the tunnel is so important for people, and knowing that someone understands this, and knowing, you know, getting onto social media about it. I'm not personally on social media, but getting onto social media about it and realizing that there are thousands of people going through this same difficulty.
Absolutely.
Shall I say something just at least briefly in what the logistics of it, what we actually do?
Yes,
Would that be all right? I mentioned earlier that we need something like a training ground, and we can do that by choosing an activity that we all do every day, and that is, like, say, sleep and eating and drinking. And so through the day, we could choose one of those, like, say, a time to get up in the morning, or a time to have a midday meal, or a time to go to bed at night, something like that. It's a start. It's as if you're drawing a line in the sand and you choose it. Supposing I choose, I'm going to get up at 7 o'clock in the morning. I mean, it could be 10, it could be 5, but I choose a time myself and I write it down and then try to keep to it 6 days a week. So we always have a day off, a day off of our own choosing. And within a very short time, that particular time of, say getting up or stopping in the middle of the day for a meal, it will become irksome. It'll become annoying. I don't want to do it. I want to get up earlier or later. I want to eat earlier or later. But we're now trying to keep to the time we said and wrote down on a piece of paper. That means we're, without realizing it at first, we're already working with this emotional energy in us, which is that urge to do what? To do what I want. So we also look at how promptly and appropriately, which I alluded to earlier with the phone, how promptly and appropriately do we respond to what calls us? You know, whether it's an email or our tax return or it's someone calling us, or the phone or the door, someone calling us by name. Does the promptness of our response and the appropriateness of it depend on how we feel? Well, for most of us, I think for all of us, yes, it does. You know, there's a knock at the door. Oh, who's that? But on my birthday, when I hear the postman knock on the door, so when I was 5 years old and I started to realize this connection, I was up like a shot, no problem. Even if I hadn't slept properly through the night, I would still be up. So it's all a matter of what I'm then willing to try to do. And we look at how much we are connected with all the activities of the day. These might be activities that interest me. You know, I'm interested in say working out some difficulty or problem, or it might be something I just enjoy, like listening to music or reading a book. Or it might be something which is dangerous, like crossing a busy road on foot. When I do that, of course, I'm always totally with what I'm doing. In fact, just walking along the street, you know, if you're, say, I don't know if you're actually in Manhattan there, you're in New York, but if you walk down, say, Broadway, you know, you try doing it just for 5 seconds with your eyes closed. I think it's not possible. Of course, people who have no sight, they're used to it. They're tuned in with their ears, with their feet on the ground. All the other senses are heightened, and they usually have a stick or a guide dog to help them. But for people who are sighted, it's very difficult. So because we depend on that. But what do I actually do? I'm walking down the street and my eyes are open, so I don't walk into people or lampposts. But I'm not with it. You know, did you notice that dog going along there? No, I didn't see it. Well, the eyes saw it, but I didn't notice it. Why not? Because I'm either thinking or I'm walking along with these things plugged in here with music or something, any sort of distraction. So we consciously try and keep on trying to come back to what the body is doing and to put myself wholeheartedly into doing it. Opening a door, you know, picking up a pencil, try to do it. If I try to do this wholeheartedly, it's first of all less likely to drop. But it means much more than that practical use. It means I will be more in the body with what it's doing here, in the activity, this life energy in the body. And what I mean by that is that if you're walking along in the street and you see someone lying on the pavement there, on you call sidewalk, the first thing you would do if you don't just step over and go on or go the other way, the first thing you do is look for movement, breathing and anything at all. If you shout, is there any response? Any response? Because that movement will show life. They're alive. If there's no movement, they're probably dead.
Mm-hmm.
So we're trying to ourselves, while we're still alive, to actually be with the life in here, not be somewhere here in orbit, thinking about the past, talking to ourselves in here about the past and the future and my hopes and my fears and my plans and everything all the time. I mean, yes, do that when necessary. I need to think, what are we going to eat tomorrow? I will go to the greengrocer or shop somewhere and get the food. So now for a few actually seconds, it takes me a few seconds to decide I'm going to get some carrots and potatoes and sprouts and so on. And that's it. That doesn't worry me. It doesn't keep replaying, but all my worries and ruminations do. And the practice is a way of getting out of those like recycling tapes that keep going round. You're stuck in the groove of it all the time. And if I say, well, this is thinking, that's another thought I've just added to it. I haven't come out of it. Mm-hmm. But if I stub my toe on a lamppost, I'm out of this immediately and I'm suddenly in my toe. Mm-hmm. But I don't recommend you kick lampposts or anything like that. Of course not. I'm just saying that if it were to happen. And with that, this can all start on day 1, day 2. With that, we start to learn how to look for emotion in us. Mm-hmm. What is going on down here, actually a bit lower down in the midriff, at the sort of lower part of the chest and the upper abdomen, the belly. And initially, doesn't seem to be anything. Some people will talk about their heart. Some people will feel tight in the chest. Anxiety, is like choking. Some people will feel nausea. Some people feel a churning or butterflies in the stomach. Some people it's more lower down in the bowels or the bladder, which it'll all affect. Because the emotion that comes up affects every organ and system of the body. And it affects every faculty and function of the mind, our attention, our concentration, our thinking, our reasoning, our ability to distinguish between what is true and what is false, our decision-making. All of it is affected by emotion. So we're trying now to become more stably or to withstand all this and try to stay here in the midst of it all. But that's very difficult to do. But we can do it. Anyone can do it if they're willing to try.
And how long do people have to work on adaptation practice and practice? Is it a lifelong thing? Like once you teach them the tools, it becomes something, or when do trainees feel like they're masters at this, or they've gotten really good?
Well, I've been doing it, as I pointed out, for a long time. I wouldn't call myself a master at it. I think that's a wonderful term. Mm-hmm. And of course, as we all know, it's used in Zen, Zen master. Mm-hmm. But Zen masters are never self-styled. It's only other people refer to them as Zen masters. But what I do is I set up with agreement to say 8 sessions. And sessions are about an hour long. They can be this long. We're now an hour and 15 minutes. They are ideally about once a week. And nowadays they're online. And after 8 sessions, so that would be 2 months of working with this, with a lot of encouragement. The encouragement, come on, you can do this, come on, try harder. But has to be very sensitive, because initially it starts with my listening to the person, how can I help you? And then I listen. And that can be anything from half an hour to an hour and a half. It's rarely longer than that. It's usually about an hour. And I won't say a word in that time. I would just listen and listen, not only with my ears, but looking with my eyes as well. And having this feeling for what's going on, all the body language in it, which we get reasonably well on these electronic devices, reasonably well. You know, if there's a tear, you know, one can see it on these.
Mm-hmm. Okay.
And having done that, we can then start to do the practice. And it's, I mentioned earlier, it's like sort of learning to ride a bike or to play the piano or something. And that we will then be able to do for the rest of our life. This is not like the piano teacher will say, practice for 20 minutes every day, dear. No, this is practice all day, 6 days a week. But nobody does it all day. I can't possibly remember to do it all day. So I put reminders around. For example, I have this rock which you can see, which is actually, I borrowed it from a mountain in Scotland. I'm not sure I'm going to put it back anytime soon, but every time I see that piece of rock, it reminds me to do the practice. It reminds me to come back to be with what the body is doing, what is going on in the body. This starts to become insight then. You know, I feel that something is wrong there, or I feel that this person is actually really trying to be kind. And what I noticed in psychiatry, especially in the hospitals, was that, you know, these people, I say these people, I mean, you know, the patients there, they desperately need love and support and kindness, and they need respect for their dignity. That was appallingly not present. So there has to be a really good rapport. You could, in a way, say, like the horse, you have to be able to come and safely, with no problem, and this doesn't happen in the human so much then, to actually be able to do that and touch. You know, one can touch one's own cheek and feel the soft flesh like that. And that rapport is the trust between each other. It has to be there. And then they will go on for years just doing the practice. They've learned what to do. Many people will come back after 6 months and say, can I do another 8 sessions or something? And I have people still contact me from over 35 years ago who will write at least once a year and say, just keeping in touch and want to let you know things are going very well. You know, one is a farmer up in the north of England. Another one is a businessman in Birmingham in the middle of England. You know, I'm still doing the practice. Why would I stop doing something that helps? You know, I'm not going to stop walking. I go on practicing or riding the bike. I ride the bike almost every day. Not going to stop.
Yeah, makes sense. If it works, why, you know, you're going to want to do it every day, all the time, and just incorporate it into it just becomes part of how you cope and deal with emotion every day, right?
Yeah. And Nicole, there's I mean, we won't have time today, I'm sure, to go into it, but there's another very important fundamental issue here. And that is, when we do this, the emotion itself changes. So I stub my toe or drop the pencil, and you know, it goes up. There's that sudden shock, which is a reflex in the body, but there's no anger anymore. There's no need to express the emotion or to try to get rid of it. You know, we've become friends because it's not just this animal nature coming up anymore and going grrr, you know, like this.
So quickly before we close then, because I don't want to take too much more of your time, but if we're not expressing anymore, are we repressing or what are we doing?
Nicole, that is such an important question,
Mhm.
because almost everybody says, surely if I don't express the emotion, which I'm told to do by everyone in society now,
Mhm.
if I don't express it, then I must be repressing it or suppressing it.
Mhm.
No, we learn in the practice how not to suppress it. And this is all what I learned in this training and practice from the Far East. But it doesn't belong. There's no copyright on it. There's no monopoly on it. It's just human activity and human nature. So I can learn not to suppress it. And I notice that when, for example, when I stub my toe or drop a pencil, that the eye, I go, like that. And it's that closing off which is suppressing it.
Mhm.
Many people go around clenching their jaw. They can do it for hours.
Mhm.
Or they get neck ache and headache because their muscles are tight like this. This is all part of suppression.
Mhm.
So we can learn not to do that, because all these activities are voluntary actions.
Mhm.
I know that if they're done, um, if they're done, and I don't realize I'm doing them, I didn't realize that I was going, like that. I didn't do it deliberately, but I can try not to do it. So I can try not to either make a fist, or if someone annoys me on the road, in a car, I'm not going to gesticulate at them, as people often do here now as well, with various numbers of fingers, or that sort of behavior. I can stop that because it's voluntary behavior.
Mhm.
And if I learn not to tense up, then it means I'm still here. I'm alive. I'm conscious. I'm awake. And the emotion has come up inside, and I've not let it out, and I've not tensed up to suppress it or repress it. But then I have to not distract myself from it. So I don't go off, I've had a bad day, and go and put the television or on the internet or on social media or plug into music here. I'm not doing any of that anymore.
Mhm.
But especially, and the most important of all, and this really hits home, is I don't go into what I call in here our in-house entertainment center of thinking,
Mhm.
trying to think of more pleasant times. Well, I might say how I feel right now. I mean, I don't mean literally. I mean, if I'm feeling angry or depressed or frightened or anxious, or very stressed, I don't awfully want to be thinking about just pleasant times. It seems too trivial and irrelevant.
Mhm.
So I try actually not to think at all about it, but try to feel it. It's like try to taste it. Taste is here, really, but we use all these as metaphors. And there's a wonderful word for it. It's to savor. We use the word savor to savor the moment. Beautiful sunset out there. And Clive, don't run to get a camera or something, because by the time you come back, it's gone.
Mhm.
But try to savor it. It means there's a wonderful way of in the dictionary of savor. It's to linger with it. Just linger with it. Just sit there quietly with it, not trying to understand it intellectually. How can you understand a sunset intellectually? I mean, the beauty of it, or love or hate or joy or misery. It's not possible. So we try not to, that's another point with modern psychology things, is not to say to myself, this is a thought. And as I said this earlier, that's just another thought in it. Or this is just a feeling. Well, I know it's just a feeling. That's why I can say it.
Mhm.
But try to feel it. And then it's very different. That's quite different. So I don't know if that answers your question, but it's such an important question.
Yes, yes. So I'm so excited to hear that you're writing a book, because I think that'll be just, a great summary of everything. And then people can really dive in and learn more about it, other than, just us talking here for this hour. And when did you say that the book might be available?
Well, I hope possibly later this year or early next year.
And in the meantime, if people want to find you or get in touch with you and learn more about adaptation practice, where can they go to do that?
Well, the simplest and the best way is, if they have access to the internet, is to go to the website you mentioned, adaptationpractice.org,
Mhm.
and there's a contact page on it. Or they can just put in adaptationpractice.org/contact.
Okay.
And there they can just put in the message and it'll email. It's completely confidential because it only comes to me. No one else will see it.
And is there anything else, Clive, that you would like to add or say to people before I tell everyone goodbye?
Well, I would like to thank you and all the team again. I've thanked you 2 or 3 times already, but I can't over express my gratitude and my congratulations to all of you and everyone in the film. It's remarkable, absolutely remarkable. And I think we've pretty well exhausted the topic of what this is, adaptation practice, by now.
Mm.
For now, I mean, there's lots more to it. Goes
Yeah.
deeper and deeper into life. But for now, as an introduction, I think that's about it.
Okay.
Thank you so much, Nicole.
Yeah, thank you so much for coming. It's been wonderful talking to you and learning about adaptation practice. And I am still just thoroughly intrigued by the topic. So like I said, I'm excited. I'll be looking for your book, and hopefully we will stay in touch too and talk more. So now we're going to close. I just want to say thank you, everyone who joined us today. We will have more interviews with more people to come. If you have not seen Medicating Normal yet, please check our website at medicatingnormal.com/watch, where you can see a list of upcoming community screenings, or you can look under the events tab on our Facebook page. We add more screenings there and update that list frequently, so check back often. We currently release new videos on our YouTube channel every Wednesday and Friday at noon Central US time. And we'll be having more live interviews here on Facebook Live every other week or so. Thank you all so much for joining us today. Thank you so much, Clive, for spending this hour and a half with us. And we will see everybody soon. So, thank you so much. Bye-bye.